Okay. Okay. Good deal.
Okay, you guys want to go ahead and start?
So shall I open mine?
Yeah. I would say whenever you want to start, you can, and we'll record.
Okay, I'll go ahead and introduce everybody, if that's okay, and then whoever can present first would be, just let me know who's gonna give it a try. But anyway, welcome everybody to today's COVID-19 Chronicle seminar series. We're very proud of Louisiana's scientific response to the COVID-19 pandemic, and researchers from around the state have been working on the front lines, conducting research to improve testing, surveillance, health impacts, and treatment. As a resource to all scientists, clinicians, and citizens, we have launched the Louisiana COVID-19 Chronicle seminar series. Started in October, the LeCat Center is hosting a virtual reoccurring of this series featuring scientists and clinicians showcasing the work being done right here in Louisiana in the battle against COVID-19. Topics and speakers for each seminar are announced to the LeCat's email list, calendar of events page, and Twitter as they're finalized. So we want to congratulate the researchers who have been successful in contributing to our knowledge on COVID-19 and hope you'll join us for future episodes of the LA CAT Center's Louisiana COVID-19 seminar series. So our first presenter, will it be you, Dr. Bojanowski? Are the slides ready?
Yeah, I think David will have to help me out.
Okay, well, I'll go ahead and start introducing you, if that's okay, for folks who don't know. Dr. Christine Bojanowski is an assistant professor of medicine and the co-director of the Adult Cystic Fibrosis Center at the Tulane University School of Medicine and the associate program director of research for the PCCM Fellowship Program. She's completing her second year as a LA CATS Roadmap Scholar and is a Cystic Fibrosis Foundation Program for Adult Care Excellence recipient. After completing a NIH Post-Bac Intramural Research Training Award Fellowship with the Laboratory of Immunology National Eye Institute, Dr. Bojanowski received her medical school training at George Washington University School of Medicine. She then completed a dual residency program in internal medicine and pediatrics at LSU New Orleans, followed by adult pulmonology and critical care fellowship at the University of California, San Diego, where she was also appointed to the T32 training program. She's a member of the American Thoracic Society and the American College of Chest Physicians. She's currently serving on both the National ATS Training Committee heading the Career Development and Research Core Training Webinar Series and the ATS Assembly of Allergy, Immunology, and Inflammation Program Committee. She's board certified in pediatrics, internal medicine, adult pulmonary disease, and adult critical care medicine. Her primary research interests are in lung immunology and host response to chronic infections with key pathogens such as Staph aureus. The title of her talk today is Active COVID-19 Trials. Thank you so much.
Thank you, Sarah. And also thank you, David, for helping me with the slides on my end. So hi, everyone. I just thought this was a nice opportunity to touch base and very quickly kind of give an overview of the landscape in terms of active trials that we have going on here at Tulane in regards to COVID-19. We've been certainly keeping very busy. We can go ahead to the next slide. So when I was first going to just kind of give this overview, this was back in December, and I just thought I wanted to keep the slide in, just looking at the global trends and, just pausing for a moment. Again, just to appreciate how devastating and just overwhelming this disease has been. So this was in December of 2020. At that time, there were 74 million global cases. The U.S. had just crossed 307,000 deaths. Go ahead, next slide. And here is from pulled as of yesterday. So as we know, President Biden is, honored this past week or recognized this past week across the 500,000 deaths in the U.S. The global cases are 112 million, worldwide. This is a great resource. It's from Johns Hopkins. It's their coronavirus map and tracker. It's a really great thing to check out if you haven't done so, although many of you probably have. To the next slide. So this is actually taken from the New York Times, which is another fantastic source. This was looking at the Louisiana cases in December. This is a heat map on the left. You can see New Orleans down there. I don't have my pointer, but I think that's all right. And then what we were looking at on the right was kind of the projected cases. And this was a really kind of high stress time for many of us as we were looking into the holidays and expecting, what really would have been our third surge in New Orleans and in our parish. And we were really thinking that we were going to be hitting pretty significant numbers towards the end of December, beginning of January. Go ahead, next slide. So these are actually the cases in Louisiana from the New York Times, still same source, as of yesterday. So this is a much better looking heat map. So, while cases globally are continuing to rise, what we've seen locally, it's been kind of hard to wrap our head around. I think clinically we're seeing much fewer patients that are being admitted to the hospital, which is definitely a great thing. And what you can see here are these 14-day changes on the right column. So across the board, in terms of cases, deaths, and those that are hospitalized have all been decreasing. So this is really a great thing for our community to be seeing, a great thing for the families in our communities, for the patients in our hospitals, for the providers. It's been really pretty remarkable, actually. I just got off of the ICU service myself this past week, and it was the first week in a year that I've not taken care of a critically ill patient with COVID. So, in fact, at Tulane, our admitted numbers, I think today were about 5 total in the entire hospital. I think at University Medical Center, the total numbers are hovering around 20 in the total number in the hospital, which is really remarkable. Go ahead to the next slide. So this is a summary of the listed COVID-19 vaccine and drug studies available on clinicaltrials.gov. So this number has continued to increasing by over 500 total number of studies in the past couple of months. There have been a couple of hundred other trials that have at least one U.S. location over the past 2 months, just in 2021. And there have been like 30 new studies that are receiving U.S. federal funding, all focused on COVID-19. So this is a really busy time. There are a number of clinical trials out there. And I would say that, at Tulane, we've been very active, which has been remarkable. We can go ahead to the next slide. So I want to go over the inpatient studies that we have currently. Over the course of the year, we've had we've done the remdesivir study, the remdesivir trials up front. I think that's one of the only ones that probably have fallen off of this list. We have these different studies that are actively ongoing right now for the most part. So we have this Regeneron study, which I'll talk about these in detail in some coming slides. But we have the Regeneron study, which was recently paused, but we'll be enrolling again soon. We have the Akaniska study, which is slowing down, but still technically open, I believe. We are actively enrolling in Generon, which is now called Evive. We are pending enrollment for an Operation Warp Speed NIH Active 1 trial. That should be starting. We should be able to start actively enrolling, hopefully within the next week or two. We are actively enrolling in a chimeric study, and then we are close to opening another Gilead study, which is looking at remdesivir in reduced kidney function. I think I have just an animation pointing that out. If you want to click, David. Thank you. So this is just a big thing because reduced kidney function has been a major exclusion criteria for many of these trials. So we missed the opportunity with many patients that have come in with COVID. And so this is a really important study because at least it gives us something to be able to offer these patients, which end up being a fair amount of patients that we have that are hospitalized with COVID. Okay, next slide. So our current screening process, just to kind of give an overview of what we do at Tulane, if the trials are coming out of the clinical trials unit, we have a designated person that pre-screens all of the inpatients at both Tulane Medical Center and University Medical Center, in addition to each of the PIs with their own screening process. Weekends, the CTU has developed pretty recently a weekend call schedule, which was not in place before. So that's been a huge help, really great. Nursing staff is available to help with dosing, but they're not doing any pre-screening on the weekends. I think one of the limiting factors that we've had with successful trials or with our trial rollouts is that we really don't have pharmacy coverage, trial pharmacy coverage at the weekends, over the weekends at Tulane. At UMC, we are able to call someone in. So that is just one of the limiting factors that we've kind of met or been challenged with during this process. So to go through some of these trials one by one, just so everyone has kind of a idea and can have that kind of bug in your ear. Go ahead, next slide. So the first is Regeneron 2066. This is the monoclonal antibody cocktail that I think most people are familiar with at this point. Excuse me. As I mentioned before, it was recently paused, but it will be enrolling again soon. It is one of the things to just keep in mind. This is the drug cocktail that's also recently received EUA approval for outpatient use. Go ahead, next slide. Thank you. So for this study, the key inclusion criteria are going to be any hospitalized patients that have been in the hospital for less than 72 hours. They can be on room air or have respiratory failure on supplemental oxygen, but restricted to just being on nasal cannula. Symptom onset has to be within 10 days. The only key exclusion criteria is that they cannot have received plasma therapy. Go ahead, next slide. Sorry, I'm coughing so much. The Caniska study has been really successful. I think they've enrolled about 11 people between the two hospitals. It is, I think, technically still enrolling, but I think there's been a little bit of a pause here. The official title is a phase 2/3 randomized double-blind placebo-controlled study to evaluate the efficacy and safety of mavrilimumab, KPL-301. What that is a anti-GM-CSF agent or monoclonal antibody. Go ahead, next slide. This study is available to anyone that's in the hospital, floor patients or critically ill patients. They have to have some degree of respiratory failure, so they have to be on supplemental oxygen. These patients can be on mechanical ventilation, which is kind of a nice option to be able to offer a trial to patients with more severe disease. Go ahead, next slide. The other trial that we have that's actively enrolling right now is one that I'm heading. It is called Evive, which is previously or nay Generon. The name just changed within the past couple of weeks for the company. But this is a phase 2 randomized double-blind placebo-controlled dose escalation multi-center study to evaluate the efficacy and safety of F652, which is an IL-22 IgG2 fusion protein in patients with respiratory failure, moderate to severe COVID-19. This is really an important study. Of course, I'm a little biased here, but we are the lead site, and we are enrolling the first patients with the first sentinel cohort. Okay, go ahead. Next slide. The enrollment for this is any hospitalized patient. Really, they need to be like floor level patients. Initially was the thought. We've kind of expanded that criteria over the past several weeks. So it's anyone with respiratory failure up to the point where they are requiring mechanical ventilation. So BiPAP is included, high flow nasal cannula is included. Some of the big key exclusion criteria that are worthy to note are any history of asthma or COPD, because IL-22, which is important at that mucosal barrier and inflammation balance. has had some conflicting results that in patients that have like asthma and COPD. Go ahead, next slide. This study is coming out of pulmonary. The PI is Joe Lasky. They are actively enrolling. It is a phase 2/3 study to evaluate the safety and efficacy of dosiparstat sodium. It's a glycosaminoglycan, a GAG, derived from porcine heparin that has been shown to have pretty significant anti-inflammatory effects. Go ahead, next slide. The key inclusion criteria here are hospitalized patients, anyone from floor to ICU, up to the point where they are requiring mechanical ventilation. They have to be on supplemental oxygen, though. Otherwise, this has a pretty favorable inclusion-exclusion criteria. All right, next slide. The ones that are coming down the way, there's a study, it's Active 1, which is from Operation Warp Speed. There's 60 sites in the country. It's an adaptive protocol looking at least 3 immune modulators given in addition to remdesivir. The first 3 agents that they've picked to look at are infliximab, abatacept, and CVC. And that last one, I just don't even want to try to say the name because I'll butcher it. But it is a chemokine antagonist. It works against CCR2 and CCR5. All right, go ahead and next slide. This again is all inpatient, so this is also for hospitalized patients. This one also will extend to both floor and ICU patients. There's some of the key exclusion criteria. A lot of them make a lot of sense when you know that you're just doing immune modulator therapies. And then next slide is this one is coming down the road as well, Act 4. The agents, the JAK inhibitor, baricitinib, has received a lot of attention. Very recently, it was published. There was a article in New England Journal of Medicine in December of 2020 supporting the use of this in COVID-19. So this is looking at remdesivir plus baricitinib, or remdesivir plus dexamethasone, or remdesivir plus placebo. And so that is still in the startup phases. So those are all of our inpatient studies that we've got going on here at Tulane. The next slide, if you don't mind, thank you so much, goes over our outpatient studies. These are all housed in our CTU COVID Research Center, the CCRC, which is pretty fantastic. It is located right adjacent to Tulane Hospital. This is the contact phone number and the email. And these were some of the studies that they've either open and closed, are enrolling, or are in startup. So the Janssen vaccine trial is already closed to enrollment at this point, but that was done out of the CTU. We are still doing the Regeneron anti-spike antibody that's actively enrolling for outpatients. The next one was inhaled. I want to say, oh no, sorry, that was the Gilead. This one was this was actually for negative patients, the Regeneron 2069 for close exposure, so that's already closed. Active 2, which is another one of the Operation Warp Speed, is going to be headed by Dr. Mushat. That's still a startup and should be starting very soon. And then there's the Gilead IV or sub-Q, which is in startup. And then the inhaled remdesivir study is already closed at this point. So there are a lot of different options that we have, both inpatient and outpatient. Next slide. The last thing I wanted to go over was just some of the non-therapeutic or observational studies that are also very important to support. And I'm sure we'll get some really interesting, hopefully helpful data from these efforts, which are listed here. So the first one, which has been going on now for the better part of this past year, is ClinSeq-SEER, is headed by Dr. Fusco, enrolling both inpatient and outpatient. Obviously, there's clinical data that's collected, sequencing data, and serum markers. So that is ongoing and something to think about. Dr. Mauvais-Jarvis can also speak more to this, and I don't want to misspeak on his important work. But I know that he was awarded a grant to look at the role of sex, metabolic disease, and inflammation in COVID-19. So if the patients are inpatient, they can be enrolled if they are at or above the age of 18. If they're evaluated in the ED and then discharged from the emergency department, they have to be at least 40 years or older. And then lastly, there is a longitudinal study just following COVID-19 in cancer patients, and this is headed by Dr. Saba. So very quick overview of the inpatient and outpatient studies that we have here at Tulane. If you have any questions, please do let me know. I'll see if I can make these slides and contact information available to everyone here. And then the last slide, which is not even relevant because we're not even on Zoom. And thank you so much for David for flipping me through my slides today. That's it, short and sweet.
Thank you so much. We do have time for a question or two if there's anyone who has anything they want to ask now, or just go ahead and speak up, or else you could always contact us or email. Okay, well, thank you so much.
I wanted to ask a question, but I don't know how to.
Oh, you can go ahead.
So, Christine, you have there are several trials on remdesivir, which, to my knowledge, by reading, has cost $3,000 per patient or $4,000, but has almost zero efficiency. What do you think about it?
Yeah, that's a great question. I mean, I wonder if they're, I think definitely with the conflicting WHO versus CDC, I think that all goes to support what you were saying with the weak data to support. I think we definitely need more data overall, if that makes even sense to say that. I don't think it hurts to get more data to kind of to help swing that dial. I don't know what I think about, I guess from a clinical trial perspective, I guess when they were designing this, did they just include it up front because it was, at that point widely accepted and being used everywhere? And so do I think it's not worth pursuing those trials because they have remdesivir on there? No. Do I think that they are going to be modifying those trials to take the remdesivir out? I doubt it, but I'm not sure. So
you think we need more data, or you think that Tulane needs more indirect costs? All right, it's not a question. It's just a joke.
Yeah.
Thank you.
Thank you so much. All right, are there any other questions? Okay, if not, we'll go ahead to our next presenter. Thank you so much, Dr. Bojanowski. So next we have Dr. Mauvais-Jarvis, who's professor in the Department of Medicine in the section of endocrinology at Tulane University School of Medicine, a staff physician at the Southeast Louisiana VA system, and director of the newly founded Tulane Center of Excellence in Sex-Based Biology and Medicine in New Orleans. He's a physician scientist with clinical training in internal medicine and endocrinology, as well as a PhD in biochemistry and molecular biology from the University of Paris School of Medicine in France. Dr. Mauvais-Jarvis has authored over 150 publications on diabetes and obesity and the role of sex hormones. He's the editor of the book Sex and Gender Factors Affecting Metabolic Homeostasis, Diabetes, and Obesity. He also serves as editorial board member of JCI Insight, Molecular Metabolism, Biology of Sex Differences, and as the associate editor of the Journal of Diabetes and Its Complications. He's the PI of research grants from the NIH and VA and has received awards from organizations including the Juvenile Diabetes Research Foundation, the American Diabetes Association, and the American Heart Association, including the March of Dimes and the French Diabetes Association. Dr. Mauvais-Jarvis is a permanent member of the NIH NIDDK Study Section, Basic Mechanisms of Diabetes and Metabolism, and he was elected to the Alpha Omega Alpha Honor Medical Society and the American Society for Clinical Investigation. Dr. Mauvais-Jarvis's funded research programs encompass basic, translational, and clinical research on the influence of biological sex in diabetes and obesity, as well as the influence of sex, diabetes, and obesity in COVID-19 severity. He will present his work on sex disparities in COVID-19. Thank you so much for being here.
Thank you for the introduction. So I don't know if what I've opened is shared. Is it?
Yes, we can see it.
Okay, it's properly displayed.
It looks like the seminar series flyer.
Okay. Yeah. Should. All right. So and does the slide moves?
Yes. Now we see the review slide.
Okay. Yeah. So we're gonna talk about COVID-19, but I just wanted to say that COVID-19 has been a spark to understand that some diseases are sexually biased, but they are all sexually biased. So I recommend all those of you who are interested in that to read this review that I wrote with some other experts in the field about the 10 first causes of mortality in the US. Of course, when we wrote it in 2020, COVID-19 was not the number one, but it's still in the review because it was starting to be important. So, and why is it that sex and gender are important in disease? Well, first of all, if you can see on the left, because the biology of sex, with sex chromosome and sex hormones, makes that male and female cells have two different biological environments, and that influence disease pathophysiology, epidemiology, manifestation, evolution, response to treatment. But you also have society that creates gender constructs that influence lifestyle, nutrition, exercise, perceived stress and smoking, and that has an influence on disease perception, help-seeking behavior, the use of the healthcare system, decision-making, and therapeutic response. So that, the bottom line is that sex is a genetic modifier of disease, and gender can be considered as an environmental modifier of disease. So why did I get interested in COVID-19? Because I'm an endocrinologist. Because for two reasons. The first one is that I realized early that it was killing more people with obesity and diabetes. And number two, like I just said, because it's a disease that is sexually biased. Two things that I like. So this is one of the first paper, New York City in the JAMA. And you see that among people who are hospitalized, they are mostly obese, diabetic, and they have metabolic syndrome. And hypertension is part of the metabolic syndrome. Much more than people with chronic pulmonary disease or heart disease. And just to give you two examples, this is the study from Ochsner in New Orleans, in Louisiana, the entire Ochsner system. And again, you see that obesity and diabetes and metabolic syndrome are very prevalent, much more, 2 or 3 times more than chronic pulmonary disease or heart disease. Okay. And this is a study that Josh Denson led, and we found that the same thing, at Tulane and UMC. You got a lot of patients with obesity, metabolic syndrome, much more than those with COPD and lung disease and heart disease. So it's very interesting that metabolic disease seems to be more deleterious and deadly to COVID patient than disease where you have your heart and your lungs that are not functioning. There's something's going on. Actually, I downloaded that this morning. This is the data from the Louisiana Department of Health, COVID-19 death. You see, 224, so it was yesterday. Diabetes, 37%, hypertension in the metabolic syndrome, 62%. Obesity then is a little down, 21%, but again, cardiac disease, 26, less than diabetes, and lung disease, much less. So again, we have metabolic disease more prevalent. And Christine will like that if she's. So why is it that metabolic disease are a risk factor for death? Well, one of the things is that obesity, there is a correlation between the increase in body mass index, in other words, the increase in fat mass, and the risk of I don't remember if it's death or severe complication, but you see that BMI is a risk factor of severity. In fact, there's actually a quasi-linear correlation between BMI, fat mass, and death. This is the probability here. But it's the same thing for type 2 diabetes. For diabetes, here on the left, you have the chronic glucose control measured by the glycated hemoglobin. And the more you have a poor glycemic control, the more you have a chronic hyperglycemia, you see, the more you have a risk of death, okay? And it's the same thing for type 1, except it's less significant because you have less people with type 1, okay? But you see something interesting, you have, when the glycemic control is very, very tight, there's an increased risk of death, probably because these people experience hypoglycemia. That's my interpretation. So both obesity because of increased fat and diabetes because of hypoglycemia are risk factors of death. And we'll see why. So what about the sex disparities in COVID-19? Well, if we go back to the first studies, the first WHO study published in New England, you see that the percent of women hospitalized, like 40%, 60% men. And it's always between 40 and 30. But when it's even more severe, primary composite endpoint is a mixture of admission to ICU, intubation, and death. Then it goes down to 32%. So there's a gradient. The more severe the disease, the less women you have hospitalized or dying, and the more men you have. So women are protected, men are predisposed. And then it went to Italy, and the Lombardy region was the most affected. And the same thing, if you look at the overall population, 80% men hospitalized in ICU, 18% women. And this is consistent across the age range. Then it went to the US. In Seattle first, but then in New York. This is the big study in New York, 6,000 patients. Again, 40% women, 60% men. And across the world, it's the same thing. If you look at the case fatality rate, you always have 1.5 to 1.8 more men than women. For some reason that I don't understand, France is not there. Like if French were not dying, but I'm telling you, in Paris, they were dying. They were all sitting at tables without masks. They are dying. Anyway, so why is it that, male sex is killing you or female sex is protecting you? Well, this review of Sabra Klein, a good friend of mine at Hopkins, proposes a few explanations. One of them, first of all, is that the entry of the virus via H2 and the transmembrane protein SS2 is sexually biased. So H2 is on the X chromosome. So, it can be the expression can change with male and female. TMPRSS2 is actually a target of the androgen receptor. So it could be increased in men. Honestly, I don't believe a second in this hypothesis. But then you have more interesting hypotheses. One of them is related to a chromosome X-linked gene that are enhancing the immune response to viruses in women, like the TLR7. So women have more gene because they're on this NDX chromosome that enhance their response to viruses. But also sex hormones are promoting a better innate immune response and adaptive immune response by promoting a less inflammatory myeloid cell environment and a better production of antibody. And it's just not estrogen, it's estrogen and progesterone. I'll talk about that later. So the bottom line is that there is both genetic causes that make female more responsive to viruses and an immune response, and also sex hormone promote a better innate and adaptive immune response. In fact, if you ask the people around you who have been vaccinated, you will realize that women are those who complain that in the second injection of the Pfizer vaccine, they were in bed and with fever. Why? Because women have a better response to viruses, but also a better response to vaccines. It's been shown a lot for the flu, for example. So I wrote this review at the beginning of 2020 in diabetes, and then I realized that I see that Franck Greenway is here, and he wrote a similar kind of similar hypothesis that one of the reasons related to leptin, one of the reasons why we have this combination of diabetes, male sex, and I didn't speak about old age, but we all know that COVID kills people who are old, is the following. So you have this so-called cytokine storm that involves immune cells spitting, outpouring pro-inflammatory cytokines and chemokines. But this can be actually enhanced by other factors. First of all, obesity and type 2 diabetes. When people have a lot of fat, they have a lot of activated and inflammatory macrophages in fat that produce a lot of pro-inflammatory cytokines. I show you IL-6, but it's TNF-alpha, etc. It's called meta-inflammation. But also increased fat produces a lot of leptin, and leptin is actually very similar in structure and receptor to IL-6. So it is a pro-inflammatory cytokine that can activate myeloid cells. And it's been shown that leptin in SARS syndrome, SARS that are not related to SARS-CoV-2, the leptin can damage the lung. So that's what obesity and diabetes can do by creating this meta-inflammation and lung damage from leptin. This is a hypothesis, the leptin. It's not been demonstrated. But also male sex, and we're going to discuss after male sex or not female sex, let's say, lead to an inflammatory immune response or less adaptive immune response. And aging, because of the senescence of the immune system, leads to inflammation. So you realize that the combination of adiposity, metabolic syndrome with its inflammation, male sex, and aging basically synergize with SARS-CoV-2 to create a perfect storm. And it's probably one of the reasons why these people are dying. Although now we're not going to see what we saw at the beginning, where we skimmed the cream of the milk, and all the big fat obese and male were dying, and but it's different now. So what about sex disparities in Louisiana? We're gonna finish with Louisiana. Again, the Louisiana Department of Health. You see, the sex difference here is much less pronounced. Only 40%. This is the death. Only 47% female compared to 52% men. But it's a big difference. In Louisiana, we have a large population of non-Hispanic Black people, 38%, compared to only 59% of whites. In addition, if you go back to the Oshner paper, you see that the female sex in whites, this is patient hospitalized, was, as I told you before, in China, Italy, in the US, 69% sorry, 40% women, so less women than men. But in non-Hispanic Black, there are more women than men, or at least as much as men. So we looked at the data. This is the study that we did, it was just recently published. We looked at the data from Tulane Medical Center and University Medical Center of all patients sequentially hospitalized, a little less than 800 between February 27 and mid-July. In other words, the first and second surge. And here's what we found. So first of all, same thing that in the Oshner study, we had this time 52% women, 47% men hospitalized. So more women. Why is that? Well, what we found is that women in New Orleans, well, at least at UMC and Tulane, downtown Tulane, which is a population, you know, urban New Orleans, a lot of them have very little insurance or on Medicaid. So it's not a healthy population, but women are much less healthier than men. Look, women are more obese than men, 60% versus 40. Women are more diabetic than men. Women have more metabolic syndrome than men, and they have more chronic pulmonary disease than men. So we have here a population where, and of course, we have 78% Black, non-Hispanic Black. So we have a population here where there is a severe health disparity in women, and they lose their protection compared to men. That's my explanation. The clinical symptoms, compare women and men, we have more women who have actually digestive symptoms at admission. And well, this could be just due to our population in New Orleans, but I'm collaborating with with a huge cohort in France, and they have the same data. Women have a tendency to be admitted with digestive symptoms. Of course, we still have more women have dyspnea and more women have fatigue here. And here's when it becomes very interesting. At admission, men were much more, if you look at inflammatory biomarkers, men were much more inflammatory, more increased in transaminase, more increase in ferritin, marker of macrophage inflammation, more increase in procalcitonin, more lymphopenia in men, and more increase in the ratio of neutrophils over lymphocytes. But now we did a multivariate analysis of comorbidities and the risk of ICU admission in order to determine some independent markers of ICU admission and death. So we looked just at ICU admission and death. And the first thing you noticed is that some, for example, severe obesity here. So in black, you have overall population. In red, you have women, and in blue, you have men. And this is a forest plot with the risk on the right increased. So obesity, severe obesity with a BMI over 40 and diabetes have similar increased risk of admission, ICU admission, men and women. But what is interesting is that COPD, chronic pulmonary disease, chronic obstructive pulmonary disease, is actually an independent risk factor of ICU admission in women, as well as chronic kidney disease in women, but not in men. And you see, if we had looked at the population, mixed men and women, we would not have seen it. So it shows you the interest of you know, desegregating by sex. But then if you look at the risk of death, so obesity disappears, but diabetes becomes even more significant. And it's a risk factor, an independent a risk of death in women, but not in men. And you see, if we had looked at the overall population without stratifying by sex, we would not have seen it. The other interesting thing is that, again, chronic kidney disease is a risk factor of death in women, not in men. Now, we looked at the inflammatory biomarkers. And here what is interesting is that D-dimer, which is a marker of increased coagulation, is a risk factor of ICU admission in men, but absolutely not in women. And troponin, a marker of cardiac injury, which is very often used for myocardial infarction, see, risk factor of ICU admission in men, not in women. If we look at death now with those biomarkers, again, D-dimer is clearly a risk factor of death in men, not in women. So inflammatory coagulation factor predict death in men, but not in women. But ferritin is a risk factor of death in women, not in men. See, in both cases, we would have looked at the entire population, we would not have seen this sex difference. Of course, you have others like CRP, classical marker inflammation. They are risk factor of death in men and women. LDH, procalcitonin, troponin, BNP, all these are risk factors of death in women and men similarly. But again, that's very interesting. The neutrophil over lymphocyte ratio, which I would say is a marker of lymphopenia, it's more sensitive. It's a risk factor of death in women, not in men. And again, if you have looked at overall, you would not have seen it. So to summarize, you see that sex and gender are modifiers of disease pathophysiology, epidemiology, presentation, clinical course and response to treatment. Of course, I give you the example of COVID-19, which is sexually dimorphic in presentation, severity, and mortality. And there are sex differences in clinical and biological determinant of severe outcomes. In women, diabetes, chronic kidney disease, ferritin, the neutrophil over lymphocyte ratio are independent predictors of death in women. But in men, it's D-dimer, which is an independent predictor of death. So you see the importance of stratification of clinical studies by sex. Because if you don't do that, you don't see anything. Let me just say a few more things. First of all, thanks to the initiative of our new Vice President for Research, Dr. Giovanni Piedimonte, we now have we are launching a Tulane Center of Excellence in Sex-Based Biology and Medicine. And we will promote and fund some innovative. It's going to be without school boundaries. It's going to involve all the schools at Tulane and research ranging from epidemiology, basic research, clinical research, translational, even bioengineering, in order to foster and accelerate scientific discovery. And we're going to train the new generation of researchers in the principles and methods to study sex-based biology and medicine. And one of the first studies that we're going to fund, and I wanted to show you that Christine didn't speak about that because, of course, it's not yet at Tulane, but because of the beneficial immune influence, immune tolerance, anti-inflammatory action of estrogen and progesterone, we worked for the last 6 months with the FDA to get a new indication for an acute treatment in hospitalized patients with COVID-19 with estrogen and progesterone. So 6 months of fight with the FDA, but the FDA liked it, and now the FDA has accepted it as a new indication, and we're going to start that at Tulane soon. So this is based on biology, it's based on hypothesis driven, and it costs nothing unlike remdesivir and all these drugs. So the study that I showed you has been done by very talented people. I mean, first of all, Yilin Yoshida, who's a junior faculty in endocrinology at Tulane. Some very talented students, Scott Gillette, Margot Brown, and Juan Hao Zhu in School of Public Health. Our junior faculty, Sarah Wilson, Sabrin Hamed, and Sarita Tirumalaceti, of course, Dr. Lovre too, and some collaborators like Tonette Crusoe-Wood and Josh Denson. I guess that's all I have to say.
Thank you so much. That was such a fascinating talk. We can open up the floor for questions now if anyone would like to ask some. Okay, well, thank you again. That was just really wonderful. And both of these talks were just so eye-opening. I really appreciate it. So from everyone, thank you so much, Drs. Bojanowski and Mauvais-Jarvis and all the attendees today. And just to remind you, a recording of today's session will be available in the next 1 or 2 days. It will be shared via the LCATS listserv and posted on the LCATS YouTube channel. So please share with your colleagues and students and spread the word about these really great topics.
And thanks for pronouncing my name correctly.
Do our best.
All right. Thank you all.
Thank you. Bye-bye.